So for my video, I'm gonna have to be going over high altitude sickness. So the way that high altitude sickness works is it's based off of your altitude, which is by definition it's considered to be a elevation above 5,000 feet, because that's usually where our bodies begin to have changes due to hypoxia, because of there being less oxygen higher up in the air. Usually, because of that low pressure, it causes changes to our CNS and pulmonary systems and causes people who are unacclimated, who are not used to it, whenever they ascend to those higher altitudes, they end up having some type of issues down the line. So, high altitude illness usually occurs in people who have rapid ascents to heights above 8,000 feet or 2,400 meters, but it can also happen as low as 6,500 feet or 2,000 meters. So usually the slower the ascent is, the more likely your body is to acclimate to the altitude, and you don't really have a risk of developing altitude sickness. But if you have a quick ascent, then your body doesn't have as much time to acclimate to it, and then you develop high altitude sickness. So three main ones are acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema, each of them with their respective acronym: AMS, HACE, and HAPE. So usually for all these, your mainstay of treatment for all of these illnesses are oxygen, descent, and evacuation. So for high altitude cerebral edema, usually they will present with the signs and symptoms of they will have a change in their mental status, they'll have ataxia, they will also progress to a coma down the line, and their mental status changes and and they can have ataxia without having acute mountain sickness. So you'll go about treating this is oxygen, mandatory descent, get them to a lower elevation, and then use of dexamethasone. While oxygen and the descent are important, the standard procedure is to administer dexamethasone as soon as possible, which it's a dose of 8 milligrams is given by any accessible route, followed by 4 every 6 hours during the descent and evacuation to keep them stable for the time being. Then we have high altitude pulmonary edema. They'll usually present with dyspnea at rest. They'll end up coughing. They'll have weakness or decreased performance whenever they get up or exercise. They can have chest tightness, congestion. They could also later on down the line present with cyanosis, crackles, or wheezing. They can be tachycardic, have tachypnea, and they may or may not exhibit symptoms if acute mountain sickness is already starting to show some symptomatic of that. So the treatment for high altitude pulmonary edema is descent and oxygen, just like was stated before, and they should have a descent immediately. Medications for treatment for high altitude pulmonary edema are limited to those where patients have descent and oxygen not readily available, whether it be a flight overseas or whatnot. Whenever oxygen and descent isn't enough for improvement in the patient, you should also consider different causes of the pulmonary symptoms, because they could have something else going on, and this cannot be the only issue that the patient is currently experiencing. Then we have acute mountain sickness, which is usually they'll present with the signs and symptoms of headache, fatigue, weakness, GI symptoms such as nausea, vomiting, loss of appetite. They'll have dizziness, lightheadedness, difficulty sleeping. Their headache also tends to be throbbing. and that's how I'll describe it. So treatment of that can be both symptomatic and physiologic. You can give Tylenol or aspirin for the headache to help with that. You can give antiemetics such as Zofran to help with the nausea. You can give acetazolamide to treat um, acute mountain sickness and help have the body acclimate to the altitude, and then also oxygen, if available, is always helpful. So, a patient with acute mountain sickness doesn't necessarily need mandatory descent to improve their status, but they should try to prevent themselves from ascending further until their current symptoms have resolved or they start to feel better. So, per se, I have my lovely patient here. Say we're on a flight going overseas and we take off really fast, and all of a sudden I start hearing her gag and whatnot. So, what we would do is she needs to throw up, have either like a bag or a towel or whatnot for her to throw up in, so that way it doesn't get everywhere. Oxygen, get a little mask, get the O2 mask, put it on, just so that way she can start getting oxygen, because the rapid ascent could have changed how much oxygen she has, and that should start helping her feel better, more calm. If this was an adult, you could give Tylenol or aspirin to help with the headache. Tylenol, 650 milligrams, aspirin, 324 milligrams. For their nausea, you can give 4 milligrams of Zofran. And then, if possible, if it was just our own plane, instead of having a rapid descent upwards, we could stay at the level that we're at now and stabilize the condition there before either ascending if their condition gets better, and then descending if it gets worse. But otherwise, it's mainly just getting the patient's descent to descend, give oxygen, and then evacuating them and treating them as need be, depending on the situation.